So this is the case. It's a 25 years old woman presented with a type 1 diabetes. She presented to the emergency department with a 24-hour of nausea and diffuse abdominal discomfort. The patient is mildly confused. Uh, she reports that she'd been missing two insulin boluses because she was taking insulin. She had a diabetes due to repeated vomiting. Over the prior day, um, she noted a generalized weakness and lightheadedness. She has no focal neurological symptoms, chest pain, or dyspnea. There is no any recent illness apart from several episodes of non-bloody emesis, which is vomiting, this thing. Her last outpatient hemoglobin A1C was 9.2, which is so much high. The normal one, which is less than 6.2. Okay. Vitals was normal, temperature was normal, heart rate was high, blood pressure was low, respiratory rate was high, and CPO2 was normal. So this is a case which is presented to the emergency, but it's a chronic case. She had a type 1 diabetes, plus she's been vomiting for the whole day. Vitals are not stable. Blood pressure 90 over 60, it's counted as unstable. Usually it should be higher than this. Heart rate was high, respiratory rate was high. Um, as you can see in front of you, that's a typical presentation of something. We're gonna affirm our differentials according to this. But what type of like physical examination we need to do before we proceed?
I think we need to smell her breath.
Okay, yes, it's actually something we need to do according to like one of the differentials could be the cause of it. Yes. What about like other physical examination? This is will be under the general or like respiratory more.
Yeah, we do a neurological examination to test neural function, maybe consciousness. We do like
Mm-hmm. You mean like mental state
yes,
examination?
mental status examination. Yes.
Also Glasgow score. There is a score called the Glasgow coma
Mm.
score to check if the patient is like with you or not, like if it's in coma state or normal state.
Like we ask them the date, where they are,
Yep,
what
yep.
time it is.
Yeah, that's part from the mental state examination. Yep. What else?
Should we check the dehydration?
Yes, this is also will be part of the general examination. What?
She's hypotensive.
Hi- Yes, she's hypertensive with this. Yeah, I'd throw your guesses. It's totally normal.
Is it called? Like hand dropping test?
This is part of the neurological examination. We gotta do this. Yeah, it's also we need to do it
Is
because the patient is mildly confused. It could be something with like nervous system. You was going to say something?
um,
Should we do abdominal examination?
Yes, I think so. Yeah, because we had an abdominal discomfort. Yeah, maybe it's a mass. Maybe it's like abdominal pathology. Yeah, we need to check.
two insulin boluses, which is like insulin inject. What
Yes, bolus it means like a dose itself,
Okay.
but like an IV. Yeah, an IV insulin. She missed
So
two
we
IV
test
insulin.
we test her blood sugar. We test her.
We didn't test the sugar. We test only hemoglobin A1C, which is it will give you a picture about the chronic disease, about the diabetes. We don't know right now how much. So this is
احنا نسميه تراكمي.
yes, yeah. This is the one. Yeah. This is like it will tell you about the patient condition in the whole month. How much is the glucose? If it's 9.2, definitely it will be high right now. But like still, we don't know.
This is an acute condition. So maybe maybe this is for chronic condition. Maybe we should test for the blood
Yeah.
glucose right now.
We will do it, but we're still in physical examination.
Okay.
So we've done general, we've done abdominal, and neurological. What else? Cardiological. So we need to do a cardiovascular test also, or like an examination because we had a high heart rate. Could be an infection.
Tachycardic, hypotensive.
Yes, and also pulmonary. Okay. So the physical examination was like this. Generally, there was an ill appearing, a dry mucous membrane, which explains the hypotension. So the patient in the dehydration stage. a poor skin trigger that like tell you that the patient is kind of dehydrated. There's no jaundice, so this is a sign to rule out like hepatobiliary stuffs, like for example the gallbladder or like a liver disease. Respiratory, we have a rapid deep respiration. Okay, otherwise unremarkable. The cardiovascular, there was tachycardia, but there is no murmurs. Uh, the abdomen, there is a well diffuse tenderness, but there is no guarding or rebound. So this is canceled like appendicitis or like an abscess and stuff. So there's only mild discomfort. Neurological, there's mildly confusion, but otherwise everything is normal. So this is canceled like stroke or like a peripheral neuropathy. So what do you think your differentials in this case?
Ketoacidosis.
DKA, diabetic ketoacidosis, yeah, could be.
Can you go back?
Yeah, we'll go back.
Hypernatremia due to vomiting.
It is. It is actually. That's what the picture looks like. But like think about right now like a diagnosis. It is. There is a dry mucus with a low blood pressure. Also of course like we're gonna test for the sodium. But like what do you think about diagnosis at all?
Hypoinsulinemia.
It is. You said ketoacidosis, which is a DKA, diabetic ketoacidosis. That will be the highest one differential. Yeah, everything looks like it is. But there's other condition looks like DKA. Do you know about it?
Wouldn't this might be a weird question, but isn't type 1 diabetes malfunctional pancreatic cells, so there shouldn't be insulin? Or is it malfunctional receptor cell?
Type 1, there is no insulin,
No
yes.
insulin.
There is no insulin.
So how could it be hyperinsulinemia if she missed the
I
insulin
said
dose?
hypo.
She said hyper.
Hypo. Okay.
She said hyper. No, hyper will be totally different. There is like a common symptoms between the hyper and hypo, but there is also difference. In hyper, you will see like sweating. Uh, there's no abdominal pain. It's more about losing like a conscious,
Mm.
not like vomiting and nausea.
Yeah, is it something in the GI?
What
It's
is it? Yeah.
also, I don't know.
The condition looks like DKA.
Yeah.
No, it's not.
It's not the GI.
It's called a hyperosmolar hyperglycemic state. Okay, this is the same as the DKA, but the only difference there is no ketones. The same condition, everything the same. There is no ketones. Why? The first one, the diabetic ketoacidosis, there is no insulin, so there's a high ketones.
Yeah.
But in the second condition, there is insulin, but it's not working in its receptor. So that's why there is no ketones, but the same condition. There's a high glucose and there is loss of
Sorry, what was the
steam.
name again? What was the name?
It's called HHS, hyperosmotic hyperglycemic state. We're gonna see it in our differentials. Okay, this is the highest two in the differentials. What about we have a high hemoglobin A1C with an abdominal pain, plus the patient have type 1 diabetes. We should think also about acute pancreatitis. Because in acute pancreatitis, you will lose your insulin, plus you will lose also the exocrine function.
No, but she's already diabetic.
Yep, because the diabetes itself, if it's in chronic state and it's not controlled, like the hemoglobin A1C, which is 9.2, this can lead to the exocrine, to my losing of the exocrine function,
Oh, that's okay.
which is acute pancreatitis. So chronic diabetes can lead to either acute pancreatitis and then to chronic pancreatitis. So we should put it also in our differential. What else? It could be also sepsis, which is like infection, because we have a low blood pressure, a high respiratory rate, a high heart rate. Yes.
What is diffuse abdominal discomfort? Can you take it?
The patient would describe like there is no pain, but like kind of like whenever they walk, they feel like a discomfort in their whole abdomen. It's not pain. It's like kind of I cannot tolerate the way that I'm sitting or the way I'm walking. It's kind of discomfort. It's not pain. No? There's my totally different between them. Yeah, we said sepsis, but we will put it in the lower differential. Why? Because the temperature is normal. So this is kind of does not go with the sepsis. Sepsis needs a high a high temperature. Also, could be adrenal insufficiency.
Yeah.
Adrenal insufficiency means the adrenal gland is not secreting the cortisol. Go.
What if we have a gastrointestinal tumor that maybe caused the vomiting?
It could be, yeah, it could be, but put something in your mind. This is only in 24 hours. So if you have a tumor, it will be for a long time. Like the patient would say 3 months, 2 months, and also would be like a gradually picture. So it start at first a little bit like my discomfort, then it start pain, then it start ischemia, etc. But this has happened suddenly in 24 hours after after not taking two shots of insulin. So kind of more acute, more than cancer together.
Are we thinking that the missed insulin shots are what caused this whole condition?
Yes, this is which is makes the DKA the highest one in our differential. Still, we don't know 100%. Could be the case, like for example, sepsis or adrenal insufficiency, but still makes the DKA the highest one. Okay,
Besides sepsis, can't it be like just gastritis?
gastritis could be, could be, but if it's gastritis, first of all, we have the hemoglobin A1C, which is high, and also missing the insulin, which is put the DKA more higher. And gastritis will not lead to this much bad situation like a low blood pressure, high heart rate. It could be, by the way, it could be if it's like a severe infection from like an abdominal viral, for example, rotavirus, etc. It could be, but still the picture is not going with gastritis. So definitely, I will put it in my differentials to think about gastritis. Could be if all the differentials does not work with our diagnosis, I would think about gastritis, especially if the patient have a history like of eating something from outside, chicken, or like my traveling outside in the last 2 days. I'll think about gastritis. Any other guess?
Yeah, I was thinking about gastric ulcers.
Gastric ulcers. Still, I will go with the same thing as I said for a tumor. It will take time. Plus, there is no any like history supporting gastric ulcer. For example, taking a medications like NSAIDs. The patient is not in NSAIDs. Plus, if you think about gastritis, you either think about NSAIDs or Helicobacter infection. Helicobacter infection, uh, it will give you more hints like about, for example, when the patient eats, it relieves its own ulcer because it's a duodenal ulcer. It's not gastric. Or, for example, the patient is an alcoholic drinker, so this is will put you more in gastric ulcer way. Got me? Okay, so those are our my differentials. DK, as I said, the highest one. When it comes to the second condition, this one HHS, hyperosmolar hyperglycemic state. When we come acute pancreatitis, uh, as we said, then we have sepsis, and then acute adrenal crisis. Okay, you have your differentials in front of you. What should we do for the workup? We should order a test to investigate. Since we have the highest one is DKA, what do you think we should order?
The ketone bodies in the blood.
Yes, ketones in the blood and also in the urine.
And yes, and we also test the pH of the blood and the urine.
Yes.
Yeah, the potassium level.
Okay, so the ketones, we order ketones in the blood.
Tamam.
About the ketones in the urine, usually we order a test, which is it will include the ketones on it. You know what's this test?
Perfect.
No, double profile is for the blood. Talk about the urine. Urinalysis. Urinalysis will show you the WBC count, the glucose,
And the pH.
pH. No, it will show you the pH of the urine, not of the blood.
But we do request pH for the blood and for the.
For the blood, we will order another test. It's called ABG, arterial blood gas. It will show you the pH of the blood, the CO2, and also the oxygen of the blood. Okay, but for the urinalysis, we'll show you the ketones in the urine, glucose, WPC, and if there's RBCs or not, and if there's glucose or not. Okay, so urinalysis, ketones of the blood, CBC we need it also because we have infection in our differential, and also acute pancreatitis. So we should order CBC. CBC will include like WPCs, for example, white blood cells, and also hemoglobin, etc. CMP is also we need CMP. It will include sodium, it will include potassium, and also a magnesium, a glucose. Why? Because if it's DKA, we need those. We need to know how is the electrolyte, and I'm gonna talk about those. Okay. What else?
Shall we order the pancreatic enzyme?
Yes, important. Which is
Lipase and
lipase and amylase. Yes. What else?
Hello?
Yes. Welcome.
Hi, how are you? We should also order blood culture and urine culture.
Why?
Why? We are suspecting maybe infection, so we want to know what kind of organism.
Yep. Yep.
Sepsis
Yep. It is. Sepsis.
for the sepsis. Do we know?
Yeah. Yeah. That's why he said we order blood culture and urine culture for sepsis. Yes. Totally correct. What else?
Hormone panel,
Hormone panel. For what?
cortisol.
adrenal crisis.
Okay. For the adrenal crisis, usually since it's not in the highest tier, in the highest differential,
No,
I will not order anything until I rule out the other stuffs. Then I will check the cortisol. Because if you check the cortisol right here and you have a picture of DKA, it will be high. Why? Because you have a stress, you have an infection, you have an inflammation. And cortisol are always high in those cases. If all the stuffs are normal, then we check cortisol. Okay. And also we don't check like the random cortisol. You need to do a test that's called the dexamethasone test. You give him a drug, then you wait for the other day, then you follow up the cortisol. It's a long process, so you keep it the last thing. Okay. Any other test you think we should order? Okay, let's continue to check. Also, chest X-ray, I think, because we have an effect.
Osmolar pressure.
Osmolar pressure. You mean the osmolarity of the blood?
Yes.
Yep. We can order this. It will be helpful. Like we can put it over the counter. Yes. So we ordered CBC, CMP, and CRP. CRP because maybe we have an inflammation or infection, so we need to check it. ABG. ABG will show you
Yes.
the pH and will show you also the carbon dioxide of the blood and also oxygen. ECG. Why? Any
Wow.
Maybe
suggestion?
hypokalemia.
Yep. Yep. Because maybe we have hyper or hypokalemia, so we want to check. We need this. It's super important. Chest X-ray. Why? Any ideas?
Infection.
Yeah, it could be infection, so we need to check it. So
Mm,
because that's not easy. Amylase and lipase also. Random
pancreatitis.
glucose. Random glucose we need to check. And serum ketones and urinalysis.
Doctor, why don't we order exercise identification rate?
Good question. ESR, you can order it, okay, but it's more for like rheumatological diseases or like chronic inflammation. So if I'm suspecting like lupus or rheumatoid arthritis, I would definitely order ESR. But CRP is more for like infections, bacteria, viral, etc.
Because I always see ESR with CRP.
Yeah, they always do this. You can do it in the clinic. It's also and it's super normal. But like if you have infection, CRP will cover it. Will cover it.
I feel like chest X-ray is just as much of a stretch as. What did I suggest for?
What?
We suggested a test, but you were like it's at the end of the differential. Hormone panel.
Oh, the hormone panel. Okay.
You don't think it's not necessary here? You said to rule out.
The chest X-ray.
Yes. Would you say
Chest X-ray is actually quite quick.
X-ray is more
Um,
important than the
Just wait for
hormone
it.
panel?
Yeah, I got you. Look, the chest X-ray. Whenever you suspect infection, put it. Let me tell you why. Because like maybe you have a chest infection and you didn't discover it from the symptoms.
Mm.
Because abdominal pain with the vomiting, it could be a pneumonia. We don't know. Maybe it's pneumonia. Because the second case we had an atypical pneumonia,
Mm.
which looks totally normal sometimes. There's no any other symptoms. So we need to do a chest X-ray to check those. Dr. Muhammad, you said something. about chest X-ray?
Yeah, the chest X-ray in hospitals is quite quick. It's not a long procedure like hormones, and we testing out with dexamethasone. It's gonna take some time.
It
The
is, yeah.
chest X-ray is quite quick, so it's really good for ruling out, as you said, pneumonia, other conditions like TB. Sometimes it could be hidden
Yep.
and masked. So these conditions are very essential to be caught early on.
It is, yeah, yeah. You're totally correct. It's like it will take a couple of minutes. So order it. That's it. Okay, let's see our labs. CBC is high, 12,000. That means there's an inflammation or infection. We didn't know. Okay. Hemoglobin is normal. Platelet is also normal. The glucose is high.
It's very high.
Yeah, 480 to 500. By the way, even like if it's not DKA, if the patient have an infection, etc., expect to be high. Even like a normal patient, expect it to be 200 or 300. Not that much high, but like it could be high. Also like in inflammations and infections. Okay.
The glucose?
Yes. That like if you test the glucose in a patient who have pneumonia, sometimes it's 250 or even like 300. It's totally normal because the body is kind of fighting infection, so it needs a high glucose. Okay. Arterial blood gas 7.15. Severe acidemia. Okay, I want to know if it's a respiratory or
Metabolic.
it is metabolic. CO2 is like 25. Is it high or normal or low?
No, it's low.
It's low.
Yeah.
The normal should be between 35 to 45. What about bicarbonate? Is 8. Low, high, what? Normal.
No,
I think it's also low.
Low, it's low.
Yeah.
The
It's
normal,
severely low.
severely low, yes, it's severely low. It should be between like 25.
really? I thought 9. 9 to 12.
No, 9 to 12, that's the onion gap.
Okay.
This one. Like the bicarbonate should be 25. So we have,
Bicarb should be between 18 and 25. That's the normal range.
yep,
I think, yeah.
higher than 18. It's more like 23 or 20 or 22. You talk about bicarbonate, right?
Yeah, I am talking about bicarbonate, but you
Yeah.
have to remember that this patient has vomited recently, and this
Yep.
bicarb lowering is very normal to happen, but down to 8 is too low.
Yep. Totally correct. Yes. Yes. If you should also keep this in your mind that whenever you vomit, your bicarbonate will be lower. But you see, this is in front of you. Is it a metabolic acidosis or like respiratory?
Uh,
What do you think?
I believe it's metabolic, but it seems like respiratory.
Okay, it's a metabolic acidosis, but why? But why respiratory?
there's like a flower graph for it, I think.
How? It's a metabolic acidosis because we have a low pH and low bicarbonate, but there is a compensation from the respiratory, trying to correct the problem.
Is it the anion gap?
Forget about the onion gap right now. We have a low PCO2, which is mean the respiratory tried to breathe more to compensate for the metabolic acidosis. So in this case, we call it metabolic acidosis compensated by respiratory alkalosis. The compensation of the respiration doesn't take time. It's usually fast. It takes like from minutes to hours. But if it's the opposite, respiratory acidosis compensated from the metabolic usually takes days or even weeks.
We
Okay.
also have to remember that the patient is tachypnic.
Yep. She had a deep inspiration expiration. Yep. What about serum electrolyte? Sodium 132. Low. The Not that much low. The normal is between
It's
135.
normal.
Yeah, it's between the normal between 135 to 130. Between
Well,
the
no, the normal end of range is 140. 130 to 140 is the normal range.
Yeah, and also because the patient is vomiting, so it looks yeah, normal. Potassium is normal or low. Normal. Potassium is normal.
Then
4.8,
it's not. Okay. What's the normal then?
3.5 to 5.5.
Oh,
But there's something I will talk about. It's normal, but still we need to check something else. Chloride is normal. The iron gap is 26. Is it low, normal, high? That's very important.
It's
Very
high.
important.
It's very high.
It's very high.
Yeah.
Very high. The normal it's between 8 to 12. Here we have 26, very high. And we calculated like we take the sodium and we it from the chloride plus the bicarbonate. So the chloride is 98 plus bicarbonate, which is 8. This is 106. 138 minus 106, it's around 26. Serum ketones, 5. Usually, we don't memorize this value, but if it's more than 0.6, that means high. Oh, here we have 5, which is so much higher. Bond creatinine, 32.1.4.
It's high. It should be 20.
It's not like this. Once we take the bond creatinine, like we don't say it's high or not. First of all, we look if it's normal or not.
I think there is a fraction 2.40 or something.
Yes, this now we use it like to know if it's an intrinsic a problem or if it's like a pre-renal or post-renal.
Yeah.
Because we took the blood test thing parameters today,
Mm.
and we're still
So you're fresh in
yeah,
that.
we're still piecing up the information.
Okay, so if the creatinine is more than 1.2, that means there is a kidney issue. So here there's kidney issue, okay, and that's a 30. That's my 30. That's my 32.
That's
So
renal.
what?
So it's renal.
It's
not
renal.
pre-renal.
No. It's my 32 to 1.4. If the ratio is my 20 to 1, means here is a 20 and here is 1, that means that's a pre-renal.
It's intrinsic.
Pre-renal.
Ah.
If it's intrinsic, it will be 15 to 1.
Mm.
So count it here around. It will be like I think it's more than 20 to 1. So that's a pre-renal. Even if you don't know this one, look at the patient itself. The patient is like dehydrated. They have a low blood pressure. So that's my picture of a pre-renal. The patient is losing fluid, which is lead to kidney issue. Not like the kidney itself. There is no any problem with the kidney. There is no like, for example, like a nephrotic syndrome or like nephritic syndrome, lupus stuff. There is no anything. It's all about fluid. The patient is losing fluid, so it leads to a pre-renal. Urinalysis positive for glucose and ketones. That giveaway. Diagnosis here. What is it? You have a ketones and you have glucose in your urine, plus you have also ketones in your blood. So what's the diagnosis?
Diabetic
Yes,
ketoacidosis.
yes,
Yeah.
it is. It is. And the ECG, sinus tachycardia without any ischemic change. So there is no any problem with the potassium, etc. So the diagnosis.
Okay, we have ketones for diabetic ketoacidosis.
Mm-hmm.
The glucose is because of the inflammation.
No, the glucose because of diabetes.
Oh, okay. Sure.
We have diabetes. We have glucose, which is 500. If you see glucose in the urine, diabetes, because sometimes it can show, but not like so much. The urinalysis, it's kind of like sensitive to glucose. So once you see it, it means diabetes. So diagnosis, DKA. Okay. The treatment algorithm is so much complicated. Okay, I will talk about it after. But after we talk about the DKA itself. Okay. What is my DKA? Do you have any like information about DKA?
It is a mix of like three conditions,
What is it?
which is diabetes, high ketone bodies, and acidemia.
Yes, definitely. I mean, now you summarize everything. Yeah, it is. From its name, it's like a condition whereas there is a diabetes, so there is no insulin, and because there is no insulin, ketones start to develop. But under the biochemistry pathways, if you have an insulin, the insulin will lead to form lead to form fat, right? Formation of the fat.
Yeah.
So if you don't have the insulin, the body will use the whole of the pyruvate in synthesizing the ketones
Mm.
because you want the brain to survive. But in type 2 diabetes, you have the insulin, but it's not working in some receptors. That's why we don't see ketones.
And type
Yes. Sometimes we see them. Why? Because in type 2 diabetes, not all of them it's about the resistant. Some of them it's about the pancreas used its own old insulin, then it will change to type 1. So there is type 2 changing to type 1. It's so much complicated. but when we think about it like this, type 1 equal to DKA, type 2 equal to the other condition, which is HHS, we talked about already. So most of the DKAs, they come to the clinic because of three things. It's either they are missing their own insulin, like the case itself, or because they had an infection or stress. So they've been taking their own insulin, but because of an infection or illness, they need to kind to increase the insulin, but they didn't. So they entered to a picture of DKA. So take care of this. Any patient with my type 1 diabetes who had an infection or illness, they need to check their glucose again a lot in the whole day because they may enter with the condition of DKA. And there's something interesting. I don't know if you know this drug or not. It's called SMGL2 inhibitors.
Mm.
Those kind of oral antidiabetics used for type 2 diabetes, they they open the channels of the glucose in the urine and increase excretion of the glucose in the urine. So in this case, will decrease the glucose in the body. But at the same time, they found that those drugs can induce a DKA. So this is kind of under my study.
Like glucophage.
What is it?
Glucophage.
Glucophage.
The dapagliflozin.
Yes, this one. Not What is glucophage? Is it like medication or what?
Yeah.
No, glucophage is insulin. It's not GLP.
I don't know. Maybe that's the name of
Glucophage is insulin.
Glucophage metformin. Isn't glucophage
Glucophage
metformin?
is metformin. I don't know this.
I think it's the
No.
commercial name for metformin
Yeah,
in Arab
maybe.
countries.
Maybe. What do you think, Mohammed? Do you have information about this since you are
Yeah,
there?
glucophage is
Saudi
not
Arabia.
GLP. No, it's normal. I think we used to give it in the hospitals for long acting insulin.
Ah, so is it like glargine insulin?
Yeah.
Mm. Okay,
Glucophage is metformin. I have an uncle who used to take.
it's metformin. Is it?
Yes,
Maybe. Let me check.
Okay, it's metformin.
it is metformin.
It's not. No, it's
No, I
not.
don't think it's insulin. No.
No, it's not. It's not insulin. Also, it's not this LG2. You said something
What?
about this medication. You named it.
Dapagliflozin?
Yes, this is the one.
Okay.
Dapagliflozin. Yeah.
Yeah, it is metformin.
Yeah. This is the one which is.
I have an uncle with diabetes. We completed all the.
You already have information about
Pharmacology.
diabetes.
Diabetic pharmacologist. Yeah.
Nice. Okay. So the clinical presentation, you have polyuria and polydipsia, and also intentional weight loss. Those three symptoms, it's only seen with type 1 diabetes. In type 2, patients will not like present with the weight loss. They present with the weight gain because there is my insulin and increasing the fat. Hypothermia, take care of this. Okay, if the temperature is less than 35 or like 34, you need to increase the temperature of the patient and increase respiratory rate, which is called the cosmal breathing. This is a typical for like DKA. The patient will take a deep breath and also take also I'm gonna give a deep expiration. So take care of this. Lethargy and confusion, and also reduced GCS, which is Glasgow score. Do you know how to calculate Glasgow score? Have you ever heard about it? The Glasgow coma score. Usually we don't do this. The nurses do this, but it's interesting thing you need.
I think we took it.
You check three things. You check the eye movement of the patient. If the patient, it's like you check the opening of the eye, and you check the movement of the patient, and you check also the alertness of the patient. So this patient is alert.
Opening, what do you mean?
For example, you call the patient. If they open their eyes, you're gonna give them 4 score. Okay. And if you apply a pressure over the patient, if they open their eyes, you're gonna give them 2. If they didn't respond to you at all, you're gonna give them 1. It's like this. It's my search for it. It's important. You need to know it. And there's a lot of mnemonics about how to memorize it. The diagnosis of DKA, fairly easy. You just might check for the glucose in the body, and also check if there's my ketones or not, and if there's acidosis or not. How is the name itself? So if you have a high glucose with the high ketones in your blood, and also in your urine. Plus, if you have a low bicarbonate, that means that you have DKA. Also, you need to ECG, as like we said, because we're gonna want to check the potassium. The septic screen, as like we ordered the urine culture and blood culture, we need to check if there is any infection or not. Renal function. For the renal function, usually if you order CMP, it will be already under it. But if you want something more fast, you will order BMB, which is a basal metabolic panel. It will have sodium, potassium, and also chloride. Okay. Coming to the treatment, which is I skipped, and this is very important. What uh, like whenever you think about my DKA, we always may think about the glucose as the problem, right? But here it's not. The problem is the ketones. Okay, so that's why we start the first thing the fluid. We start zero point 0.9 saline fluid. They always ask this in the exam. They bring the case of DKA, a high glucose, etc., and then they ask you what's the next step. And all the people jump to what? To insulin because they okay, there's a high glucose, then I'll give insulin. No, don't do this. First of all, you're gonna replace the fluid because the patient is losing a lot of fluid, vomiting and ketones, etc. Then you're gonna give insulin. The fact that insulin here is not important at all. Yeah, the glucose is high, but we need to treat the ketones. Okay, so you start fluid, and you're gonna page the endocrinologist. You're gonna call them because this is an emergency, or you're gonna put this patient in the ICU. We need to follow these patients because they may die. They may die because of cerebral edema. You see how much it looks easy, but they can die from it. Okay? So replace the fluids and replace the electrolyte. Very important. When you check the potassium, for example, in this patient was 4.8. 4.8 is normal, okay? But the insulin normally it shifts the potassium inside of the cell. But here we don't have potassium. Sorry, no, we don't have to have the insulin. So all the potassium will be shifted outside of the cell. Okay. So in the blood looks like normal, 4.8. But if you count the whole potassium, it will be low. So we need to replace the potassium, even if it's high. And our cutoff will be 5.5. We're gonna keep it in 5.5 until we treat the acidemia. Once we get rid of the acidemia, then we stop the potassium. We're gonna keep it like this, between 5.5 and 5.2. And you're gonna order every 30 minutes the potassium to check it. Again, 30 minutes, you order it again and check again and check again. You're keeping this patient in the ICU, huh? And you are keeping giving the fluid. And then when it comes to the glucose, you will give me the insulin, okay? But your aim will be of a glucose more than 250. Why? Because here we have a stress, we have an inflammation process. We don't want the glucose will be less than 250. Why? Because if it's less than this, the body cannot tolerate what's happening, and infection will happen. A kind of situation looks like sepsis. So we don't want this. We want to keep the glucose more than 250.
You said that what takes potassium inside the cell is insulin.
Yes.
Then why don't we replace the insulin before we replace the potassium?
Let's say we replace the insulin. All the potassium will shift inside the cell, right?
Okay.
Then you will have a low potassium in your blood. Boom, your heart is pumped. You will have an arrhythmia. Give the potassium and then give the insulin. Okay, replace it. Because any change, a small change in the potassium will lead to arrhythmia. And you don't want to see arrhythmia, trust me. Arrhythmias are so bad. CPR, etc., and patient will die. So replace the potassium. Okay, I'm continuing this part. Let's get messed again. Probably I need to check this issue to fix it. Anyways, we stopped at the electrolyte losses and how we replace it. We already talked about the fluid replacement and the electrolyte. When it comes to the insulin replacement, at the time which is we started our fluid replacement and the potassium replacement, we're gonna start insulin, okay? And the choice will be any type of insulin, preferably be the regular one, not the short acting or the longer, but whatever available you can do, preferable regular, okay?
and we're gonna start our insulin and keep it going until we fix the issue, which is the acidemia. Okay, so no matter the glucose gets low, we will keep our insulin working, and even if it get to a point which is lower than 250, in this case we will give glucose. Okay, we don't care, we're not gonna stop our insulin until we reach to our target, which is two things: getting the pH back to its normal value, which is 7.35 to 7.45, and get rid of the acidemia in the blood and the ketones. Okay, super important, guys. And we're gonna monitor our patients till the ICU until the patient is stable. Once we get to our target, which is normalizing the acid and get rid of the ketones, in this case we're gonna stop all the management. We're gonna switch from IV insulin to the subcutaneous one, and we discharge the patient. Okay, and of course seek the underlying cause. Before discharging the patient, knows what is the cause of DKA. Is it because of missing medication? Is it because of infection? Because of stress process? Take care of all of those and follow it. Okay, I think this is the part we miss. Thank you all for watching.